Welcome to the virtual edition of SAM 20, brought to you by COVID-19. This session is a brief introduction to academic emergency medicine's new guidelines for reasonable and appropriate care in emergency medicine, the GRACE Project. I'm Chris Carpenter, and my co-presenters today are Fernanda Bellolio and Suneel Upadhye. Next. My conflicts of interest are primarily academic. I serve a number of academic roles within the Society for Academic Emergency Medicine. I also serve on the ACEP Clinical Policy Committee. Next. The Guidelines International Network defines guidelines as statements that make recommendations intended to optimize patient care informed by a systematic review of evidence and an assessment of the benefits versus harms of alternative care options. Currently in emergency medicine, there are no guideline-forming agencies. The American College of Emergency Physicians forms clinical policies, but not guidelines. Academic emergency medicine sees an opportunity with the GRACE guidelines to identify conditions that are commonly encountered in the emergency department, cause diagnostic dilemma or treatment uncertainty, are associated with significant practice variability, and routinely elicit medical malpractice concerns. Next. The Society for Academic Emergency Medicine has over 7,000 members. We want to encompass all of that membership as we form these GRACE guidelines, picking topics and questions of premier interest to our society. That includes all of our members, our academies, our interest groups, committees, the board of directors, and external groups when appropriate. We're going to be guided by a steering committee who's going to select topic experts each year that form a writing group, and the overview of the evidence and the strength of recommendations are going to be guided by the grade criteria, which we'll talk more about in just a minute. We're also going to include patient advisors to give us the very important and probably essential patient perspective. We're also going to have a firm dissemination plan. Next. The timeline for developing these GRACE guidelines, which right now we hope to put out one new guideline per year, includes selection of a topic and topic experts in the spring of each year, January through March. Then the topic experts identify and engage a writing group in the March through May period. The steering committee and writing group develop the PICO questions in June and prioritize those PICO questions and the outcomes of those PICO questions before a medical librarian then completes a search strategy in August of that year. Then the evidence oversight panel screens the search findings in September, and then October through December, systematic reviews for those PICO questions are developed. The writing group then creates guidelines for each PICO question in January through April of that year, and in May of that year, we use grade to rate the quality of strength of recommendations. And then, next slide, ultimately publish these in academic emergency medicine. Next slide. I'd like to introduce Suneel Upadhye, who plays a prominent role in guideline development in Canada. Suneel, take it away.
Thanks, Chris. So by way of disclosures, I have a couple of academics as well. I'm a decision editor with the Canadian Journal of Emergency Medicine, and I chair the Standards Committee for the Canadian Association for Emergency Physicians as well. Other than that, I have no commercial conflicts to declare, although I am for sale. But the Canadian dollar is cheap right now, so I can be had for very cheap right now. Anyway, next slide. So what is GRADE? So GRADE is an international collaboration that's been going on for almost 20 years now with a broad multinational representation of guideline experts looking to increase transparency and openness and due diligence in the creation of guideline products so that can increase the trustworthiness and the usability of the final products and recommendations, and that's what GRACE has chosen to embrace. Next slide. So this is a busy picture, but we're going to take it a piece at a time. So in the center of the graphic, you'll see the panel. The steering panel is what guides the entire exercise, including experts in content for emergency medicine. There might be non-emergency medicine experts involved as well, depending on the topic of interest. There might be policy organization people, there might be insurance people, there might be malpractice lawyers involved, depending on what the questions being asked are. And as Chris pointed out before, there will ideally be a solid representation of patients and end user stakeholders so that they can guide the topic priorities appropriately. Next slide. So when you look at the way GRADE is broken up process-wise, the upper half of this graphic suggests how the systematic reviews and the evidence are evaluated. So if you click again for me, you start in the top left corner formulating your PICO question. And this has been well covered in the past, so the PICO parameters are well familiar to researchers. And then you have your outcomes of interest, and they'll get rated up and down based on their importance to the various stakeholders in the panel. And ideally, patients should have a large input in this as well. Next button. And as you work your way across the studies, then you're following ideally Prisma level systematic review methods where you're rigorous with your approach to the evidence, you're broad with your searches, you're transparent and duplicative with your evaluations of the literature that you've retrieved, and you can start evaluating it using appropriate critical appraisal tools, and then extracting the information of interest for your outcomes, and then feeding them into the grade tables, which create what are called summary of findings and summary of evidence tables. We'll take a look at that in a second. Now, fortunately, Grade also creates some online supports using the Grade Pro software, which you can sign up for free at the Grade Pro website. We'll take a look at that later as well. So eventually, as you filter your way through the retrieved evidence and you decide this is high quality, moderate quality, low, or very low, and they have a 4-star rating system or crosses or whatever graphic you'd like to use, but it's a 1 to 4 rating system one nonetheless. And as you keep going across, click again, you can find that the evidence may start to move up in quality if you have a large effect estimate for the intervention of interest you're looking at, a dose response, and you can account for opposing biases and confounders to get to the truth of why this intervention does work for the way it does. On the flip side, you can rate the evidence down if you find that there's significant evidence of risk of bias, whatever tools you're using to look at that, inconsistency, indirectness of the evidence, imprecision of the evidence, so it's not giving the same answer over, and evidence of publication bias using funnel plots or Egger analyses or whatever you want to use. Now, if you're really interested in reading these topics in great detail, the Grade series, explanatory series of papers in the Journal of Clinical Epidemiology, which is available at the Grade website, has one article on every one of those topics. And if you have absolutely nothing to do during this COVID period, then by all means go ahead and read them. And if you need something to help you put to sleep, that's a great series to read. So that gets you through the evidence. Moving down into the bottom half of this graphic is where the evidence now gets translated into recommendations. So what the panel ultimately wants to do is give a recommendation that's either strong or weak, or conditional if you want to use that, either for the interventions of interest or against the interventions of interest. And that's an intuitive way for clinicians to think. Click the button, please. And as you move across the bottom part, you'll see that Grade also offers in their software something called the E to D framework. So evidence to decisions allows you to put in the evidence that you've surmised during your systematic reviews in the panel above. And then you get to balance out things like, what are the balance of benefits and harms? And there's a few questions in the framework that ask those questions. Values and preferences of patients and end users is very important. You get to enter that information in the E to D table as well. You get to put in some commentary about the feasibility of the interventions in your workplace, equity issues, applications for resources, what have you, and ultimately what are the cost effectiveness of the interventions being discussed. Click, please. And then at the end, you get a overall recommendation either for or against the interventions of interest for the questions that you've been asking. And the strength of those recommendations will be either strong, which would guide behavior change for physicians, patients who are receiving these treatments, or policymakers and what have you, or weak and conditional, where it's not as emphatic that you should be doing what the evidence suggests could work rather than should. Thanks, Fernanda. Next. So what the Grade program does that is probably more explicit than other frameworks out there is it has a very systematic, very stepwise, structured approach to evaluating the quality of the evidence and then feeding that forward into a ratings generation framework. It's now a tool that's been picked up by most of the international organizations worldwide, including WHO, AHRQ in the United States, the Cochrane Collaboration, and so on. There's some websites at the bottom that you can connect to if you want to go explore those sites a little further to see how Grade is utilized by these organizations. Next. And there's just a graphic on the Grade website about the different organizations, including WHO, ACP, the American College of Physicians, Up to Date, CHEST, the Surviving Sepsis Campaign. There's a couple of Canadian organizations there that are also using it. So lots of organizations now have picked up Grade. It's probably now the international standard by which most guideline organizations produce their products. Next. So again, to summarize what the advantage of GRADE might be versus other CPG frameworks, you just click as we go along. So it's developed by a wide representative of international developers. There's a clear separation, next, of the quality of evidence and the strength of recommendations. There's explicit evaluations of all the important outcomes that have been prioritized by the stakeholders. There's explicit comprehensive criteria for upgrading and downgrading the evidence. There's transparent processes for moving the evidence into the recommendations to that bottom line of the graphic we saw. And then finally, there's clear and pragmatic recommendations of strong versus weak recommendations for all the end users, the clinical, the patients, and policymakers. So it does have its strengths. Next slide. So again, looking at how the evidence is translated through, just a different representation. Like most organizations, randomized trials dominate the strength of the high-end, highly certain, high-quality trials that get translated into summaries and then into practice guideline recommendations. And then case reports and observational studies, especially retrospective stuff, tends to be lower on the food chain. Next, as described, we lower the certainty of evidence and our confidence in what that information is telling us due to things like risk of bias, inconsistent results, indirect results, imprecise results, and evidence of publication bias. Next, and then we get to bump that up if you have a large treatment effect, a dose-response gradient, and accounting of all other plausible confounding factors and bias. And that finishes out with a 1 to 4 star rating, or if you like the little Phillips head of a screwdriver, whatever that is that you want to look at. 4 is good, 1 is bad. Next. Also, the software will spit out a summary of findings table, and there's a variant of this called summary of evidence tables, but we're going to show you the summary of findings table. And if you just go through this column by column, it summarizes all the evidence in a nice, clean representation for the outcomes of interest that you've defined. In the middle, you're going to see the comparisons between the intervention and the standard treatment or intervention that you're looking at, and then you start getting into the relative effects for the pooled outcomes in the next column over. This particular table is also showing you the number of participants and the number of studies that contributed strength to that outcome of interest, which is on the horizontal line. The final columns are going to be the quality of evidence on that 1 to 4 star rating system. Ideally, you want it to be moderate or very high. And then the authors might put in some comments about the evidence or some specific details to explain the evidence. So in one clean little table, you get all of your evidence summarized. Next, and ultimately though, what the user may want to do is cut to the chase and say, tell me what to do. So a strong recommendation or a weak recommendation, either for an intervention or against an intervention, is intuitively obvious for most of the consumers out there who want a quick and dirty answer. Next, and this is the kind of rating that GRADE gives. And it turns out that clinical people like GRADE compared to other frameworks that give you recommendations like level A, B, C, 1, 2, 3, that AHA-ACC uses, and there's other systems out there. When tested head-to-head, at least in this group of pediatricians, looking at some treatment for gastroenteritis, the details don't matter. When they looked at the recommendations that were presented in different frameworks, including GRADE, the majority of the respondents said, we like the GRADE style because it gives us the information we want and tells us what we need to do. So this is a study that's begging to be redone in emergency medicine, but I suspect that the answer would be the same. Next slide. So again, other strengths of GRADE beyond the transparency of the evidence translation into the recommendation frameworks. GRADE does a very good job of dealing with observational studies, which other frameworks are not as facile with in terms of how they're treated and evaluated. There's a very heavy emphasis on patient values and preferences priorities for the outcomes of interest to make sure that the guideline panels are on the right track and not just pretending they know what the patients want or care about, but actually asking them. GRADE does a better job of dealing with systematic reviews and guidelines around diagnostic testing strategies as well as therapeutic interventions. They do allow for what's called good practice statements. They're not big fans of it, but they do allow for good practice statements when the evidence is just insufficient to allow recommendations at the guideline level. The GRADE ad allotment, sorry, that's a mouthful, but I don't know what that exactly stands for, but the bottom line is it allows for things what I like to call sanctioned plagiarism, which is where other organizations create critical practice guidelines And if those recommendations and evidence profiles have been done well, there's no reason for an emergency medicine authorship group to not take that information, adapt it into the emergency medicine sphere, give them the appropriate credit that the original authors did, and do an adoption of that information into emergency medicine and reframe with a new lens, strong, weak, for or against. And finally, GRADE is probably the best strategy out there for looking at resource utilization assessments and what have you. Next slide. So all of this information we've talked about is available at the GRADE website. Right there, you can see the link. There's lots of useful information there. The tools of how to sign up for GRADE Pro are there. There's tutorials available. All the source articles are available there as well. So if you are inclined to and you're interested in learning more about GRADE, this is your starting point. And I'll pass off now to Fernanda. Next slide.
Thank you. Thank you, Suneel and Chris. So my disclosures are also mostly academic with the funding from NIA and AHRQ. I do have some intellectual property or patents pending for an artificial intelligence platform with medical record. That's not related to this work that we're presenting today. Next. So the first GRACE topics, we already started working on recurrent low-risk chest pain for this year and also recurrent abdominal pain for next year. As Chris and Suneel mentioned, we started working with creating 8 PICOT questions: patient, intervention, comparison, outcomes, and time. The patients, for example, for the low-risk chest pain is patients with recurrent chest pain, defined as 2 or more ED visits for chest pain in 12 months, and with a negative cardiac workup. Low risk, we define it as the HEART score or other validated scores in the emergency department settings. For outcomes, we're looking at acute coronary syndrome, and for time, within 30 days. We divide all these PICOT questions in 2 big groups. One that are the intervention questions, for example, looking at the role of stress tests, and the other group are the prognostic questions. For example, the role of a negative cardiac cath. Also, we're looking at the role of depression and anxiety screening tools in healthcare use and return ED visits. As already mentioned, the methods included that a librarian conducted the search. We got more than 5,000 titles that Chris, Suneel, and I reviewed in duplicate. We pulled all the full text that were eligible and applied those to different PICOT questions. We passed all this information to the systematic review team, led by Mike Gottlieb. We have had in-person meetings, including a patient representative, and we have had several communications with the GRACE writing workgroup. Next. So what is the ideal state for GRACE? So it's mostly 3 things we want to highlight today. It's to provide information that will support us, clinicians, in making clinical decisions, including shared decision-making when there is equipoise. So each guideline will have 3 things: a plain language summary, or patient shared decision-making instrument, if applicable or available. We also are looking for endorsement for the Guidelines International Network. For those of you that haven't heard this before, the Guidelines International Network supports guideline development, adaptation, and implementation to help create high-quality clinical practice guidelines for safe and effective patient care. So we're looking for their endorsement with our guidelines. And third, we want to create or adapt GRACE guidelines with an international appeal. We want that our guidelines will be applicable to other resources and settings, including some non-academic centers or other countries. Next. So we acknowledge there are going to be some challenges working with the guidelines development. One of the challenges we anticipate is going to be funding and sustainability. We know that larger societies receive funding from the society itself, but also through some grants to keep their guidelines evidence-based and transparent. Also, we think balancing topic selection with SAM members' interests or needs is going to be very important. Another challenge will be meaningful patient stakeholder engagement. We will continue to have patient involvement, and we're learning on how to make this engagement more meaningful right now. Another important challenge will be updating GRACE guidelines. We know that new evidence becomes available every day, and as more evidence is available, we will need to update the guidelines. And the last one that we recognize so far is avoiding some overlap or discrepancy with other guidelines or with ACIP clinical policies. Chris, any other challenges you want to add?
No, I think those challenges are very real, and GRACE is well prepared to meet all of those challenges. We got funding commitment from the Society of Academic Emergency Medicine Board of Directors. We have 7,000 members at SAM, including 8 academies, 16 committees, and 30 interest groups. We have a large swath of individuals with tremendous expertise, the world's expertise in academic emergency medicine. So next slide. We are going to need everybody's voices and engagement to provide us future GRACE topic ideas. What are the areas of medicine that we really need to be addressing with the GRACE guidelines? Give us constructive feedback on each GRACE publication as we learn how to put these guidelines together and put meaningful implementation packages and patient-shared decision-making packages together with each of those. And if you're interested, please volunteer for one of the GRACE committees. We need all of you. Next slide. So in conclusion, I hope this gives a idea of what the state of GRACE is, that we've got the guidelines for reasonable and appropriate care in emergency medicine, clinical practice guidelines that are evidence-based and transparent using the GRADE methodology that most of the rest of the guideline world is using. We've created the first topic, then the second topic is now getting underway in May of 2020. There's going to be a lot more topics and we need all of you to be involved. Next slide. Since this is virtual and you don't have the opportunity to ask questions, we are going to leave you with our email addresses. Want to make sure we give acknowledgements to the steering committee who have been engaged all year long, the recurrent chest pain writing committee group, the senior editorial board of academic emergency medicine who have given us lots of feedback and kept us on track, the board of directors of Society for Academic Emergency Medicine for their support, Hassan Murad and the GRADE Network for giving us essential GRADE training and volunteering their time to help us succeed, and Stacy Rosine at Academic Emergency Medicine Offices for her editorial and dissemination support. Next slide. Please email us with any questions that you have, and we'd be happy to answer questions, comments, feedback, or ideas. Thank you.